emailed my so then I thought, oh, don't have to. And I have.
So, good afternoon, everyone, and you're all most welcome to today's conference, focusing on the consequences of living with HIV infection from the women's, children's, and men's perspectives. Our speakers are Lorraine Scher, a clinical psychologist and professor of clinical and health psychology at University College in London, and José Catalán, who is an honorary consultant psychiatrist in South Kensington and Chelsea Mental Health Centre in London. Their HIV-related clinical as well as research work are very substantial and very, very impressive. Together with Barbara Hedge, who also lives not in London but Liverpool?
She's now in Kent.
In Kent, okay. Lorraine and José initiated and launched the first AIDS Impact Conference in 1991. It is an international behavioral and psychosocial science conference that addresses issues related to HIV and AIDS prevention, treatment, and care. So let me now leave the floor to Lorraine Scher, who will address HIV challenges for women and children, a global overview. Her presentation will last until 2:30, followed by a coffee break, and José Catalán's presentation will start at 3 o'clock and runs until 4:30. And after that, we would like to hand over Guldarken that I will talk more about when time is like 4:30. So please, Lorraine, take the floor.
Do I need it?
No,
Oh, does this do? You can all hear me, even if I whisper. Ah, wonderful. Well, good afternoon. It's a real pleasure to be here and also a privilege. I've tried to put together loads of work that we do and that I'm involved in, just to get you some kind of an idea, a taste of what's going on. But what I'm hoping really is that you will interrupt me, that you will ask questions and that you will talk to me. In fact, if you're all very quiet and nobody asks me any questions by about half an hour, I'm going to assume that you are asleep and I'm going to sneak and go and see the wonderful city of Stockholm. So let's begin. I work a lot with women and children, and I'd like to give you some idea of psychological well-being and mental health, which is my area of focus, but it's all kind of intertwined. We know that people with mental health problems are more likely to become HIV infected in the first place. So there's a lot of evidence and data that shows amongst members of the population who already suffer, and we can understand the reasons for that. So, for example, if you have a mental health problem, you may be more likely to have a risk behavior. Some particular mental health burdens, like, for example, alcohol use or drug use, it links you into the behavior. So it's a complex kind of cycle. And we also know that people with HIV, even if you never had a mental health problem to start with, may well develop a mental health problem, and they have more burdens than the general population. And of course, you who've worked in this area would know the kinds of reasons to trigger that, the trauma of diagnosis, the impact on relationships, the impact on jobs, on economy, on family. It becomes a kind of a mushroom and very, very complex. And we also know in this kind of circle and cycle that mental health problems can have an adverse effect on very important elements of the epidemic, an adverse effect on transmission of infection, an adverse effect on living and coping with HIV, and of course indirectly on the health outcomes. So if it has an adverse effect on adherence to your treatment, your health outcome is compromised. We know that you do have to adhere for lifelong treatments at the moment, which is quite a burden. So what are the mental health sequelae of HIV? And that's one issue, but there's also mental health sequelae of the treatment. And we're seeing in our clinics people who are reporting things like treatment side effects. For them these days, this is the first illness experience that they have with HIV, is the treatment side effects. So living with these side effects and coping and adjusting with them all provide a very complex sort of mosaic of HIV and mental health. What I'm going to try and focus on for you today is I'm going to look a bit at HIV in women. Oh, yes, you're awake.
For just another second.
Oh, sure.
We just decided to take a picture and we wanted to be awake.
And I will leave it with Elena, so you can we can circulate to everybody and save your cameras, but take pictures with pleasure. With pleasure. Do you have your picture? Good. So that wasn't a real question. That was a request, but not a question. So I'm looking at you and I'm waiting for a good question. So what I'm going to try and do today is to talk a little bit about HIV in a woman, a little bit about children. Much of my work with children is based in Africa, but it's nice to talk in an audience who are already nodding. You know, artificial boundaries are strange. So medicine divides obstetrics and pediatrics. Psychology doesn't. We just see childbirth and the new baby as one. Politics divide countries. This is Africa, this is Europe. Who are our women in London? They're very often people who have migrated from all over the world. They come from and they go to. So we have different kind of boundaries. And I'm going to end my talk by what I think is a new and emerging problem. It's a tomorrow's problem, but one that we haven't given enough attention to. The advent of mother-to-child transmission prevention really means, well, for certainly, I don't know what it's in Sweden, but I know in my hospital we haven't had a positive baby born for maybe 9 or 10 years. I'm sure that that's the situation here. But what about HIV-exposed, uninfected children? What do we know about that? Are we studying them? Do we know what's going on with them? And I want to give you some insight to that group, what we know, and maybe a future research and clinical agenda. Okay, so now we have a bit of a marathon, lots of very interesting things. I find the whole area so fascinating, so excuse me if I give you too much information, and if you want, I've left out lots, so if you have any questions, do ask them. Now, what is the gender differences of the impact on HIV? And I've tried to look through the literature to kind of give you an overview and a synthesis. Some women report very much shame and guilt associated with HIV infection. When you look at the quality of life studies, very often women have scoring lower on quality of life. We do not know if this is triggered by HIV or just compounded by HIV. It may be that that would be true in other diseases. We do know that women's sexual activity is adversely affected by HIV infection right from the moment of diagnosis and for many months later on. We know that it has effect on health-seeking behavior, medication adherence, and clinical outcomes. Very well documented in terms of the gender differences. And what are they? When you talk to the women, they report decreased sexual desire. Some women report very poor sexual functioning and sexual inactivity, and that's quite commonly found. The coping strategies and the ability to disclose their HIV, to tell others about it, to partners, and sometimes the partnerships break down, so the ability to form new partnerships and relationships, and empowerment to practice safe sex may be affected negatively according to gender. So women have a very different and very special role, which we really need to understand. What are the burdens? Well, I'm listing them, but I think anyone who's done work in this field will know that this is just an indicative list. Economic burdens, employment, children, family, relationships, migration, very true in London, and I'm sure it's true here, support, disclosure, and of course stigma. Stigma is a strange animal which is associated with HIV profoundly, and it affects people. It affects their own views of themselves. It affects what they do. It affects how they live and how they adapt and cope. I have some data on women in the UK, and I think maybe it's very similar, and I'd be interested to hear if anyone knows about the exact data in Sweden. But just as of this last year, when the statistics ended, we had 31,600 women living with HIV in the UK, so it's large, and 31% of people living with HIV in the UK are women. We also have an imbalance. When you look at heterosexual men in our statistics, we find a report of 19,000, and heterosexual women living with HIV, the numbers are higher. Now, what is that imbalance? Is it that women are more likely? I mean, I believe it's probably that women are just more likely to be diagnosed. They're more likely to be tested. The imbalance is probably reflecting the way that we actually have neglected heterosexual men in the UK, because women are routinely tested in antenatal care, routinely. And so we have a different profile. They're not coming forward when they're sick. They're coming forward early on in the course of disease, and have been for a long time. So very curiously, when we did a study now, 9 or 10 years, we put a question to the staff, amongst many questions, was, do you test the men? It's such an obvious question. And we were laughed at. This is an obstetric clinic. They said, did you get your questionnaire wrong? They were laughing at us. Women have babies. Excuse me, but what about fathers? So to them it was almost ridiculous. It was a very interesting dialogue. Maybe 9 years later, they might come to the... But the whole idea that you have a pregnant woman with HIV and you don't think it's a normal routine to bring her partner in. And then some of the obstetricians said, oh, well, you know, Lorraine, some of these women, the partner's not the father of the baby. So what? She's probably still having sex with the partner. You know, it's a kind of almost paternalistic attitude, and very strange, but I don't know if you have the same difference in the numbers, and sometimes the numbers don't tell you the whole truth. Your action in terms of your testing and your outreach is what tells us the truth. So when you try and look at the mental health of women, it's also very interesting because the literature really focuses a lot on HIV and reproduction. So we know quite a lot about pregnant women, but that's only 9 months of a woman's life. And, or maybe, you know, in the UK you have the mean number of children is 2.2, so 18 months of a woman's life. And the rest of her existence we don't really focus on. So there's more to women than just childbearing, and there's more to women than mothering. And our models need to understand that and take that into account. And then again, with aging and HIV, there might be very specific considerations of HIV in a woman. So I'm looking very forward to Dr. Catalan's talk later on this afternoon to see if we do know what are the differences, what are the needs, and what is the state of the data. That's at the one end of the scale, the aging. What about the bottom end of the scale, the young woman? Well, again, when you look at the stats, and I've given a talk at UNICEF, when you look at the data, have you ever looked at the UNAIDS statistics? It calls for children. If you're under 18, you're a child. You come under the child, adolescence and child. Suddenly you have no gender. You only get a gender when you turn 19. So, and isn't that crazy? You know, and I promise you, I've said to UNAIDS myself, disaggregate by gender for all children, we want to know. And when you look at studies, you find very interesting differences in the number of boys born, in the transmission rates between boys and girls, in the IQ, cognitive impact. We need to know this gender data. So we're gender blind for 18 years, and then we wake up. So I want to present findings from our study looking at the challenges for women, and I'm going to discuss a little bit of our findings from one little study in London, but I'm going to be quite quick about it. And the study preceded a nice study that's going on at the moment that hasn't concluded, called the PRIME study, where we've gathered, and Shima Tariq is heading up on that study, which I'm involved in, gathered data from over 1,000 women in the UK. And I think that it is a really good example of what needs to be done, and other studies that might be important to look at, trying to gather data on your own woman. These are the mental health factors that I've seen: quality of life, depression, anxiety, coping, disclosure. And I also always talk, when I do, that we shouldn't concentrate on negative mental health. We also should look at positive mental health, like resilience and coping, because we have a lot of resources that we do need. Mental health is not necessarily always negative. It could be good, could be good. From our experience, it's just 3 steps. The first step is you have to identify mental health problems. If you don't identify, you won't find them. And it's very interesting. If you look at the clinics, people have routine viral loads, they have routine tests, we have routine data that we gather. Why is it not possible to simply put in a routine mental health screen? Very easy. You can do that at baseline, and then you can see if they change, if they go up, and you can identify the problems. Very often the barrier is that clinicians don't know what to do with it. If we find a problem, what do we do? So we have 2 pathways. You either deal with it, or you refer it. And that's quite straightforward. And I think we can do a lot of training, because a lot of mental health problems could be dealt with by the primary physician or the primary nurse or caregivers. But I think, organizations like this, that's a good place for referral. If we can't deal with it, at least refer it to a place who has the time, the expertise, the resources, and the caring to do it. And once you refer, you have to have something to offer. You have to have interventions. And is there evidence that we can do something? Well, there's good evidence globally. We can't get rid of it all, but we certainly can have good interventions. And what are they? Well, it's a literature that would keep me here for a long time, but my plane is tonight. So I'll just try and summarize some of the interventions. These might be familiar with you. I'm not sure what you do in your groups, but psychosocial group interventions, there's quite a lot of good literature that says these have benefits for many people. And when I looked at a very nice systematic review from Van der Heijden last year, they picked up 16 trials, and they're showing very good effects. And when I looked up those trials, 10 of them were men and women, and 2 of them were women only. So we do have some data on women. And it showed that these group interventions had a small effect on depression, but more limited on anxiety, coping, and stress. So the evidence in that review was not great, but it was there. The EVE study in France, a smaller sample size, large number of side effects, only half have found self-care strategies to manage. So this was just looking at naturally what were people doing, and quite interested in what did people go out and find solutions for themselves. And Beres has done a review of non-specialist interventions. And if you look at the 9 articles, quite mixed results, but some had effects and some not so good. So what did we do? This is just a study of women in the UK. We took all the women in the clinic in my hospital, and we interviewed them. We used some standardized mental health measures, which I'm sure you're familiar with. We looked at anxiety, we looked at depression, we looked at symptom experience. We particularly wanted to ask about suicidal ideation, and we looked at sexual functioning. And very interestingly, we also wanted to look at menopause, because many of the women are experiencing menopause symptoms, and are they getting any care or any help? And this is just who we recruited. This is just at our center. So we had 272 women who came through the door, of whom 251 were eligible. We excluded people whose English was not sufficiently good for them to complete the questionnaire. And of those, 170 accepted to participate. It was about a 67% response rate. And then we had 140 usable complete questionnaires. Some of the scales, you have to have an answer on everything to get a validated score. So if you didn't complete the questionnaire fully, it was not very usable. Who are our women? They were aged 21 to 60. Many of them were well educated, 33% with university, and roughly half were in a relationship currently. And the ethnicity was quite mixed, Black African, Black other, white, or some other ethnic minority. And I wonder, this is probably very similar to what it looks like in other European cities, I'm sure. That might reflect some of your institutions. Looks very different when I do studies in Africa. So we looked at general health and treatment. Most participants led quite healthy lifestyles. Only 26% had ever smoked, and of our women, only 8% smoked currently. Less than 20% drank alcohol on a weekly basis. 85% of women had never smoked or injected drugs, and 95% of women had had HIV antiretroviral medical treatment. So a very high uptake of treatment. And I imagine this is not typical, because wherever I've worked, this really reflects a hospital, or a centre of excellence hospital, and a country where you have free HIV treatments and care available on a national health service system. I even imagine, like in the USA or in South America or other European countries, we might see a whole different array. But that was our women. And our treatment adherence looked quite interesting as well. 95% were on treatment. Of those, 82% had started but not stopped. Then we looked at how many doses they'd missed in the past week, and you can see it's slowly going down. So it's wonderful to say 95% were on treatment, but then you see it chips away. No doses missed in the past week, only 63%. All doses taken under the correct circumstances. So now the newer compounds, you don't have to have such difficulties with with diet or timing, but that goes down again. All doses taken in the correct time period, and only 46% had kept to the same regime. So slowly you see the treatment experience showing a very different picture. What about mood? What did we find? So looking at some of the psychological symptoms, 90% reported worrying, 90% reported feeling sad, 81% feeling nervous and anxious, 80% irritable. So there's a lot of findings. I just picked those up just to try and reflect to you that here you have this large group, but very, very high burden of mental health problems. So let's look in a little more detail. Anxiety, no risk for anxiety. And on the scales you have a cutoff, and the cutoff is to indicate where you would perhaps refer. It's sort of indicative of a diagnostic of anxiety, and perhaps that's a point where you would refer on to psychiatry or psychology. So mild anxiety 14%, moderate 11%, and severe 8%. So that's quite a high burden of anxiety. And when we look at the at depression, 55% had no risk of depression. So remember that there are a group who are doing fine and who are doing well, and they at that point in time are okay. But 29% had mild depression, and 14.8% had quite severe depression. And half the participants, and it's very, very high, reported that they had suicidal thoughts in the previous 7 days. And we do know from the suicide literature that suicidal ideation is a burden in its own right, but it's also quite predictive of people who do go out and have suicidal acts very often had suicidal thoughts that preceded them. So that's a worry. Pregnancy, most women had at least one child. 26% of the women had no children. 12.4% had a child who had died. Remember, a woman whose child has died, that's a bereavement which is lifelong. Women don't get over that. It lives with them forever. And 58% had experienced pregnancy loss. So they'd experienced either a miscarriage or a termination, and 20% of those had experienced it multiple occasions. And the cause of the loss, high rate of termination of pregnancy, high rate of miscarriage, and 4.4% stillbirth, which is elevated compared to the general population. What about the satisfaction with care? So you can see pretty much very high satisfaction rates, but this sort of small little group of people who were not satisfied, who were not respected, who didn't have good discussions about their delivery or about feeding the baby, and that shouldn't be there. It should be, everybody should get a good service. We looked at the sexual functioning index using something called the FSDI, which is an index which says the lower score, you have greater severity of sexual dysfunction. And we found greater than 23 normal sexual functioning, 18 to 23 was mild dysfunction, and then it breaks it down to moderate or severe. And the mean score for the group was 20.2, which I suppose falls into the mild dysfunction range. So it does show you that there is something going on there, which is worrying. So looking at the mental health burden, we were also quite interested because we'd measured anxiety, we'd measured depression, we'd measured suicide. Did that cluster? Were there people who had one and the other? Were there people who had comorbidity? Did they have lots of it? And we found, we tried to divide them into those who had no mental health problems at all, those who had single burden, and those who had multiple burden. And we found that the mental health burden was significantly associated with symptom distress, physical, psychological, and with sexual dysfunction, and with adherence. So basically, we're finding that the intensity and the level of mental health burden is affecting. We don't know which comes first because it's cross-sectional. Does the mental health problem link to the adherence, or does the adherence link, which way does it go? But the associations are there, and the call that we do need to deal with these mental health burdens is very clear, very clear. And then from the study, we also looked at the older and the younger. Not going to go into such detail with you on that, but just to let you know that we used 45 as the cutoff, was sort of taken as a mean age of menopausal, and we did see some interesting differences. Elevated anxiety in the older woman, more above the anxiety cutoff, slightly more symptoms, both physical and total, in the older woman, more depression above the cutoff, or suicidal thought wasn't significant, but it was so high, 1 in 2 across the age range. And here we've got 1 out of 2 mental health problems, 2 out of 2, or all 3. And we find if they've got all above the cutoff on all 3, the suicidal ideation is elevated. We did give some detail on mental health for the woman, and let's move on to look at what we linked the symptom distress to. It was linked to mental health burden, to adherence, and to sexual functioning. So that's just our small study, but I would like to just briefly tell you about the PRIME study, which is being headed up by Shima Tariq. It's really interesting countrywide. They've got 22 clinics in the UK, and they're aiming to recruit about 1,000 women, starting to write up some papers. They've got over 1,000 women in the database, and just by way of a taster of the data that's coming from this, they are focusing on menopausal symptoms, and this is just showing you the kinds of symptoms that the group are experiencing. They divide them into premenopausal, perimenopausal, and postmenopausal. So there's sort of 3 groups in the age range, and you can see that there's quite a lot of symptom, and it does change from premenopausal over to peri and post quite significantly on all of the symptoms, psychological, urogenital, and some of the somatic symptoms. So that's taken me all through the kind of issues around women, and I suppose now I want to move over to what I'm calling little women, to look at children and adolescents. I've mentioned before that children have a kind of a double neglect. They're overlooked by age and by gender. I spoke to you already about that, the classification not giving us the gender. So as I look at children, I want to try and keep in my mind something about the needs of girls, but I don't think we should ever forget the boys. And let's tell you some of the data that we know globally on the children. Now, most of my data comes from Africa, but many people who work with adults don't really have a working knowledge of what's going on with children, and that's really important because as time goes by, these children will be your adults. They're coming through the system, and in a clinic where we divide by age, it's very different from a help institution like yours, where you have families and you bring them in. We could even see the lovely painting where we had our lunch, and we thought we might, as somebody explained, that the children and families come in. So having a family lens is really important, and that's kind of how I work. So I'm just going to try and give you some of the overview data. So there's been several systematic reviews on HIV-positive children, and I won't read you all the data, but basically there's very profound evidence that when you take the children with HIV and you score them on standardized developmental scales, the children on the whole seem to be performing at a lower level. Not all children, some children are fine, but if you take a large group and you compare them to a comparison group of children without HIV, you do pick up some specific cognitive delays. And the challenge now is to understand what are the areas of deficit, what are the areas. And so some of the emerging studies, if you start to look at, are finding things like some of the executive skills are more problematic. Now remember, executive functioning skills are the very things you need to negotiate the world, to negotiate safe sex. So it's not just the children are perhaps underperforming in class. Their whole life trajectory is something of importance. The HIV-exposed, uninfected children are also a group that we need to focus on. I've given some data to you, but these are the children who are born from an HIV-positive mother, and they themselves are born HIV-negative. It was always thus. In the whole of the epidemic, there was never 100% of the children born. There was always about between 70 and 80% were virus-free. And now with antiretroviral treatment in pregnancy, the numbers go down dramatically, almost to the possibility of eliminating HIV in vertical transmission. And of course the problem with breastfeeding, in that we do know that breastfeeding can transmit, so children who are born free could then become infected through breastfeeding, and we now know very clearly that if the mother is undetectable, very much like the PrEP studies of what we know about the virus, that if she's on treatment, the chances of breastfeeding transmission also go down. So we have got this whole new B+ program rolling out, where basically once you pick up a woman, she goes immediately onto treatment, and she stays on treatment lifelong, which also gives protection for when she conceives her next child. And of course that's obvious that people kept seeing pregnancies as isolated. women have more than one child and you could protect. So the world has changed, and it really has changed, but these are the children of the future. The majority of children will now be born HIV-free, but exposed in utero. So they're exposed to the virus, they're exposed to the medication, and they're exposed to a household where the child is going to live where HIV resides. And we know that HIV is burdensome, and we don't know what effect it has on the child. So these are a series of interesting studies. We're just showing mortality. The studies were set up to look at HIV-positive children. And the reason I bring them up was some studies took HIV-exposed uninfected as their control group, as well as HIV-unexposed uninfected as a control group. So some good studies had 3 groups, and it's those that I'm interested in, because we know that this is elevated, but I'm not interested in that. I'm interested in this. And look at every point, and those are significant. So we're so busy looking at this, and that's kind of the historical, because now we shouldn't get children born, but this is our future. So that's where the future of understanding this group is. So what are the estimates? These are very kindly UNAIDS provided these to us for Amsterdam, but I'll bring them to you. These are the age groups of the estimates of children living with HIV and children HIV exposed and uninfected. And you can see by age, this is by far the majority in the 0 to 4-year-olds. 5 to 8 years old. The largest is the older children, and they will age out. They will age out. But you can see this is our future. This group is our future, and those are the children who we have to be looking at. So, how do we study these kids? Do we study these? And what do we ask? What are the questions? What do we want to know about the vertically infected, or the kids who are maybe in Africa? We're now getting these groups who are infected from their mother during pregnancy, or the groups who are infected through their behavior, and they look very different. So I'm just bringing you some data from some of our studies. This particular study looked at the effects of multiple things on child risk behavior. So here we showed that if the child lives in a healthy family, the chance of a risk behavior in the child, these are adolescents, was 1%. If the parent is sick with AIDS, the child's risk behavior goes up to 7%. If the child is abused or hungry, so they have insufficient food and they're subject to violence, their risk behavior is double that, and 13 times living in a healthy. But what happens to the children who have it all? And this is the data that we think is very important. This is the reality of many of the children. They live in an AIDS sick family. They experience violence and abuse, and there's insufficient food. And that's what happens to their risk behavior. So when we're trying to say, oh, we have to give them information about AIDS to change their risk behavior, our answer is no, 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 no. What you have to do to change their risk behavior is stop violence, stop hunger, and help and treat the parent. That's what you've been doing. So I brought you that because that's really, UNAIDS we're hoping, listening to some of the stuff we're bringing. And we're very interested in these combination effects. Now, this data does come from Africa, so I don't know. It'd be interesting to see if you think this is true in your setting. Is this true in London? Not so sure. But here we've looked at the experience the kids have of getting a cash transfer, getting good experience in the clinic, and getting good care, a sort of positive prevention. So we looked at 1,000 HIV-positive adolescents, and we looked at what happens to their unprotected sex. And these are positive adolescent girls. So if they've got good parental supervision, school access, and positive clinic care, those are the rates. So if they've got no provision, 1 in 2 are having a risk behavior. If they've got any of these, it really dramatically brings down their risk behavior. But what happens if you give them clustering? So they've got school access and good parental care, and we know parental care can be easily learned from good parenting programs. It goes down. If they get good parental care and a good experience in the clinics are quite horrible to the girls. They shout at them. when they come in for pregnancy advice, we're now doing a study on the pregnant teenagers with HIV because they have such a negative experience, and of course their children will be the third generation, the new generation. So, but we haven't got that data yet. But here, if you get two, a good school and good clinic, good parenting and good clinic, or good school and good parenting, the risk behaviors come down. And what happens if you're the lucky kids who get all three? Good parenting, supervision, access to school, and decent clinic care, the risk goes down from 49% to 8%. So when everyone says, well, you know, does all this behavioral, psychosocial stuff matter? Yes, is the answer. Very clearly, yes. It's not about magic bullets. It's not about delivering medications. It's about finding holistic environmental support, and that directly affects risk behavior. It directly affects adherence. It directly affects the very variables that we think are important. And this is just a nice slide on adherence, and we've tried to align it with some of the social protection types. And it's the same message that you can see. If you get no social protection, that's the risk behavior. And if you get everything, so we're looking here at adherence to treatment. It's the same thing for risk behavior and also for treatment. So finally, I'm going to try and show you a little bit of our other stuff. Lots of studies, but this one is showing you our findings on suicidal behaviors, and we just found quite high. This is a study of 3,500 adolescents, aged 10 to 18. This is a study in South Africa, and we looked at past month suicidality rates. 3.2% had attempted suicide, 5.8% had clear planning for suicide, and 7.2% were reporting thoughts and suicidal ideation. And what were the predictors of being in those groups? Well, orphanhood by AIDS was a very important predictor for both males and females, and parental AIDS illness was a great big one. So this is the legacy burden. These are the children who are surviving yesterday's epidemic, and they're living with it, and they're very burdened. And this, we've tried to just show you the difference between suicidal ideation and psychological morbidity when there's no HIV in the family. Those are the levels. Remember, these are very poverty, children who are living in great poverty anyway, very demanding environments. And here's a household affected, and if the caregiver is actually HIV positive, and you can see the rates going up. So a lot of mental health burden. Disclosure is a big issue, telling the child, telling them about the status. If you want some good advice, there's been a very nice WHO document giving guidance on disclosure when really thoroughly looking at the literature and saying when should you disclose to a child. I chaired that group, and I think that it's really sensible and well thought through guidance, really saying a child of 12 should know. You know, how you do it is very difficult. And a lovely study by Tams and Rochart reported in the Lancet last year, where they put the Yamagugu trial, where they actually put together a really nice package to train and prepare families for disclosing HIV status. So there is interventions. When we did the study, we actually found that the best adjusted children were those who said they never remember a disclosure moment, they always knew. And that's our advice, really. So you shouldn't have to sit down and tell a child. If you tell the child always, so the child always says, I always knew. When it's like the onion approach, you peel a layer and layer. And these children say, well, I knew from when I asked more questions, I got more information, but I always knew. So in a way, disclosure is a fascinating issue. You can see from what I've been saying that we need to understand bereavement a little bit more. We've got a lot of children who are living with bereavement, either historical death or bereavement. Nowadays, HIV is not creating the same number of deaths. luckily, but there's other losses, there's other bereavements, loss, distracted parenting, that's a grief for a child. And really we do know that children whose parents died 10, 15 years ago will live with that fact for their entire life. So we shouldn't let go of that. And finally, I'm just going to try and give you a little bit of information about the HIV-exposed uninfected children. Where is the literature? So this is the state of the global literature. On the biomedical, there is some emerging literature with very mixed ideas. Mixed means there's some positive and some negative. That there's no evidence, and that is there is evidence. And you can just see it's a mixed picture of these children. Is their health, illness, and survival and drug exposure is mixed. No problems with dental health. There's some good studies, but things like their own mortality, pulmonary infections, hearing loss, mixed on cancer. No difference on immunization, but that could be more about policy, and there is evidence on tuberculosis. So these kids are getting a very mixed profile in terms of their biomedical, but their cognitive development, there's very good evidence. So we've reanalyzed all the data. Remember I told you before where we sifted through the studies which had HIV-exposed, uninfected, and control groups, and you can see literally on almost every study we do find a difference. There's been a few studies, but this is a really good one, a group, if you want to read up on it, called McHenry, who've actually done a meta-analysis and reanalyzed the data. It's confined to children who are less than 8 years old, but again, they were able to identify 45 studies and found that HIV-positive and HIV-exposed uninfected children showed worse cognitive and worse motor development. So there does seem to be a growing body of evidence that this is a group of children who we need to show. And this is just more slides just showing you. What's really interesting in our review is that we couldn't find any data on adolescents. The data is confined to the younger children. But we did find lots of interventions. So if you say, well, what are we doing? Are our hands tied? No, I mean, I've just summarized the studies, but there's good cognitive rehearsal, stimulation, give them good parenting to the parents, and it's an all beneficial effect. If you treat the maternal depression, the child development scores improve. Nutrition, community support, antiretroviral treatment, disclosure, cash grants, cash plus grants, and parental survival. It's no brainer that keeping the parent alive. And be aware that we sit in Sweden where we have good treatment outcomes and good rollout. But think of Nigeria where they've only got rollout to something like 48%. Those parents will not survive if they're not on treatment. The nightmare scenario that we lived with 10, 20 years ago is a real scenario for people who don't have access to treatment. And if treatment was ever stopped, if PEPFAR was disbanded, if UNAIDS and the Global Fund didn't survive, this would be our reality. And we have made amazing progress. Where else in the world have we come up with something like the Global Fund? I think we really should pat ourselves on the back. I mean, you can't. I was in places where you can't get clean water to drink the pills, but these are very complex medications being delivered everywhere. I think we've done very well, but we should keep it up. It just brings in.
I'm just wondering, would you like to take a 5-minute break, or do you want Lorraine to continue?
I'm pretty much at the end, and I think we'll take some questions. I've just literally got one or more two things which I brought because you are a community-based organization, and we've been looking at whether community-based organizations can have an effect on mental health. And I can show you the slides, but really the answer is yes. People said, how can you study this? And I said, you can study anything. And we got 11 funders, and we took every program they had, and we took a random sample. So things like Comic Relief, World Vision, UNICEF, huge funders. And we went out and we took questionnaires, we followed the kids up for a year, we took their caregivers and the HIV positive, and the bottom line is Yes. That's the statistics, that's what you tell your evidence-based programmers, but we really can do it. And so the literatures really suggest that we should screen, refer and treat, partnering with organizations and providers, broaden the provision, examine tools for assessment and use them, and anticipate mental health issues, prevent and provide, and partner, I suppose. So that's all I've prepared for you today, but I really would hope that we would have time now to have some questions and discussion. I hope I've... Yes!
My name is Thomas Wingberg. I'm the chairman. Hello, thank you very much for the presentation. My name is Thomas Wingberg. I'm the chairman of Positive Group, which is an NGO for people living with HIV in Sweden. Maybe I missed what you said before, but I would like to ask you, when you talked about sexual dysfunction, I think is the word you used,
Yeah.
right? Yeah. Is that something that is diagnosed officially, or is it your self-diagnosis, which I'm asking because I think that many times you have to diagnose yourself for sexual dysfunction.
So in the studies, I mean, that's a perfect question. And you have the thing is, what is a problem for some person might not be a problem for another person.
Right.
But in the studies that I'm reporting, what they've used is standardized inventories where people complete and in there is this a problem for you? So not having, some people are quite happy not to have a partner and it's not a problem for them. So the inventories, so in a way we have to be a little bit careful with them. It doesn't mean that everybody has a problem, but if you take it in a large group and you do find that a lot of people saying, I have a problem and I've never spoken to anyone about it, it worries me, it's upset me, I wish it wasn't like that. In a way, that's the group who we think deserve some treatment. And we also think that caregivers are not very good at asking about these things. So people hold the information in, they don't talk about it. It becomes a taboo. We can't talk about it.
Yeah, that's why I ask if it's a sort of a self-diagnosed dysfunction, because I found that probably everywhere in the world, this is one of the questions that are less talked about when you...
Yes, I agree with you completely. Yeah. And at some level, when somebody realizes, actually many people experience this, I'm not alone, for them that's a very important moment. Because some people suffer alone and they can't talk about it. And then maybe they come into a self-help group and everyone in the room, and they go, oh my gosh, everyone's having this. And suddenly you've started on the road to help.
Right.
Good.
Hi, I'm Anne-Marie. Thank you so much for your presentation. I'd like to know the difference between mental positive and negative.
Between?
You said mental health positive and mental health negative. So I have never heard of that positive side of it. I thought mental health was negative.
Oh, okay. Yeah, oh, lovely question. I was trying to think which slide I was talking about. We always, when we're thinking of mental health, we always tend to be talking about depression or anxiety or post-traumatic stress. These are all kind of not such nice things. But on the other hand, you see in my work, you see some children who are very resilient. They're amazing. You know, they've suffered a lot of food deprivation, perhaps parental death, and these kids are working hard and really doing well, caring for other kids. We see in some of the self-help groups, you often see people who say things and you say, what is this? They say, this is the best thing that happened to me. Before I was really off the wall, had a bad life. Now, my life, I have a purpose. I'm helping other people. It's a positive. So I think that, to me, is the positive mental health. And we should balance that. We shouldn't always look for the bad things. We should encourage the good things. And coping is good. I mean, some people cope amazingly. We want to know how, and can we share that with other people? And it's just maybe a philosophy of trying to keep the positive as well. And I'm glad you heard it first from me. Is that clear? Yes. Okay, thank you. Have I stunned you into coffee?
Just to mention, one of the issues was whether this is... So just, okay, so I'll keep quiet, shall I? Or?
No, no.
No.
What's your question?
I'm not allowed to.
No, no, you've got a mic.
Yes.
You don't
I
have to
see
use
this
the mic.
One of the issues, whether this is with sexual problems or with mood or other issues, is that much of what the person is prepared to talk about depends on how they're going to be listened to. So if the practitioner, whether it's doctor, nurse, counselor, whatever, is going to panic and not handle it, then obviously you don't generate those questions. But also, even if you're sympathetic, if you have no way to refer this person on to something more specific, so it depends on the whole context. Just simply being nice to people and saying, yes, tell me all about your problems, unless you have somewhere to go to. And I think that's where we often fail. We know what the recipe is. We know what the things we need to do are, whether this is supporting people at school or intervention to help parents to handle difficult situations. But if those things aren't there, then you just get stuck with the evidence but with no action. And then the practitioners sort of shy away from it. Because what's the point of identifying problems if there's nothing I can do? If everybody's depressed, then I'm just going to get depressed because they're depressed as well, because I don't know what to do. So it's part of a range of approaches. It's not just us doing the right thing. We need to be in the right context in that sense.
And we've in the past we've done things where we've videoed interviews, and you look at the questioning style, and there's a lot of, we call it blocking questions, where people ask about, they say, oh, I asked about it, and they didn't tell you. And so when you analyze, they say things like, you don't have any problems, do you? So they believe they've asked, and the message to the client is, don't go there. Don't mention your problem, because it's the way they framed them. And so you have to be able to show you really want to hear them, or you've got the time to listen. Otherwise, you're right, Pepe, people will just not feel, or they'll say the doctor's very busy and it's more important they get my drugs right. So in the room, they will rank order what they discuss, and they will discuss what they think the doctor thinks is important. Do any of you work with children? Work with children? I meet
some children that live with HIV and also not. Yes, I meet some children who live with HIV, and I meet also children who live in families with HIV.
Yes, of course.
So,
yeah. Yeah. And we don't ask about that. We did a study once, it's a while ago now, where we asked MSM about their dreams of fatherhood and if they had children. And everyone said, why are you doing that? Wow, very interesting data we found. Many have children, many dream of fatherhood. We make all sorts of assumptions. So, often I have people say, oh no, I work with MSM. I think, oh yeah, well, come on, so...
I have one question about breastfeeding.
Yeah.
Is it any studies that is going on about the next step about breastfeeding and when the treatment is so good nowadays?
So there's continued monitoring studies, and the new regime, the B+ regime, is really meant to encounter that, because in the past they would prevent mother-to-child transmission and the mother would stop treatment, which nowadays it's treatment for life. So there is monitoring. There's not really studies because it's sort of unethical now you can't have a woman and not give her. So there might be some studies that's comparing the compounds. And that's not in my area of expertise, but I know that in Amsterdam there was a large issue that came up from the Botswana group who were monitoring, and dolutegravir was having a higher than expected rate of neural tube issues. So there's discussions about which compounds should be used in pregnancy and maybe in breastfeeding. But that's where it is. I think the treatment guidelines are treat during breastfeeding, and it's released them from the previous things of exclusive breastfeeding and formula feeding. and the reduction of transmission postpartum has really helped enormously by onward transmission. Yeah.
Thank you.
Pleasure.
This is not so much a question, but a reflection. Yeah, I think you used the word disclosure. Is
Yeah.
that? Yes. I've been living with HIV for almost 30 years, and one of my strongest memories is when I saw, well, this is way back in time, a young boy. There was a documentary or something about him, and he never got to know from his parents, but he saw on television and identified another man talking about his AIDS at the time, and he realized himself that this man on the television had the same diagnosis, the same sickness as I have. And this is a very sort of heartbreaking, strong memory from, he had to deal with it himself because, this was not, the advice was probably never to tell him. And he found out himself by looking at television when another adult person talked about AIDS. So I think this is a very important subject, and your conclusion is probably the right one. Yeah.
There's so much on disclosure. I agree absolutely, and if you, the cycle of secrets is very damaging, and you're absolutely right. I mean, this is one example, but very often you have children who just know. And I mean, I can tell you about cases. There's one that's a long time ago, but I remember very clearly the parents couldn't bring themselves to tell the child, and the child was quite poorly. So the clinic set up a big, complicated situation where they would go with the parent, and they rehearsed, and they role played with the parent. So they were going to prepare the child and prepare the parent. And the parents just couldn't, and the parents asked the clinic to talk to the boy in advance, which I think is bad, but anyway, they did. And the boy said, "Oh, I know." He said, "I read it on my phone. I know." He said, "But please don't tell Mummy and Daddy, because they'll be very upset." So the child was colluding with the secret. The child knew, and the child kind of had taken it on board. So we have all these crazy situations. But while we have stigma, we have disclosure challenges. And remember that when you disclose to a child, it's not like telling a child about cancer, because you're also telling the child about the parental status as well, and that makes it a little bit more complicated. But, the old psychology advice is, if in doubt, tell the truth, because the truth could be painful, but at least it's the truth. Yeah. That's it?
I was just wondering about the uninfected children in the HIV family. I was surprised about that there was more people in the studies over there. You had data on physical consequences that had been shown. But is there any material? Have you any studies about the psychological well-being of uninfected children in a family where one or several people are HIV positive themselves?
It's such a big area. It's a great question. So this is sort of a very new area of study. We do have some data. Our study is from Malawi, South Africa, and Zambia. And we do, there is a burden for these children. And they divide very differently. What's very interesting is there's children who have sick parents, there's children whose parents are deceased, and there's children who are moved to another family and in a way, it depends on what stage they're at and historical. But the data from the big cohort with Lucy is showing that historical AIDS and parental death and parental illness is having an effect on the mental well-being of children. And we need to unpack that. We need to understand what it is. But we can understand that there's, first of all, bereavement, loss of a parent, irreplaceable, but then sickness, very diverting. A parent who's worrying about HIV is not concentrating on being a stimulating environment for parenting, all of those things, very diverting. And we also know that parents who are depressed, the children don't develop as well. This is from the general literature. And we also know that there's a lot of depression associated with HIV. So a lovely study by Mark Tomlinson and Mary Jane Rotherham Boris have shown that if you put in, and it was a very easy study, they put in a mentor mother, training her on mental health into the homes of postpartum women, so this is young children, and they showed that the development of the child improved when you treated the maternal depression. It wasn't development intervention, it was mental health for the mother intervention. So it's a growing literature, it's all over the place. So there was a very nice satellite meeting that we pulled together in Amsterdam, just focusing on this group, and we've now applied for funding to look specifically at this group, but they haven't really had the attention that we need to be giving them.
Yes, I was wondering if your experience, according to your experience, if they are forgotten or if their needs are addressed to, as well as the children who are HIV positive themselves.
Yeah. They are really overlooked. So the people who are doing very good work is somebody called Kate Powers in Canada and Amy Slowgrove in Stellenbosch. And there's some nice stuff going on in Botswana. And I think we're trying now to create an international collaboration to pool the data and to look at these children. And many of the families say, oh, once the child's born negative, we don't want to, that's it, you know, close that chapter, we don't want to talk about HIV, just get on with it. And they don't want the child. But if the child has needs, we need to understand them. So I can't think of one study in Europe that's following these children. But we hope we get funding and become the one. Join us. Yeah. Tomorrow's problems. We're always thinking of yesterday's problem, not tomorrow's problem. Good. Tea time.
Well, I would like to generalize a little about Swedish people. We are a bit hesitant sometimes to express our questions or comments in the public like this. But as there will be some coffee, you might be really heard a lot of questions and comments.
Very welcome.
So I think unless there are some more comments or questions, maybe we should take the coffee break right now, and for about half an hour, and then we can go on with Jose, and that will give us a little bit more time for the Golden Ark and to mingle after that, so you don't have to rush right away to the cab and the airport. So I want to thank you very much. There is a lot of important facts here that we really have to consider. And I think it's really interesting that children are very much forgotten, even in this country, I would say. Both those who do have HIV infection, but also those who do not have infection. So I really hope that this was some, you know, your emphasis on women and children, that is something we can take with us and see how can we develop our work within our NGOs. And don't always trust the healthcare system. Thank you.
Thank you.
would love to come again if you want us to. And
Jaha, då är det dags. Now it's time to continue. Let me just say that the next speaker says Dr. Pepe Catalan.
I will explain.
No, and I was concerned. I didn't want to use your name Pepe because I thought that was kind of a more nickname family name. So that's why I introduced as José Catalan. But anyway, we'll now continue with living and aging with HIV, and Pepe Catalan will then be the presenter.
Thank you. Thank you very much to you, Lina, and to everybody for inviting us to come and share these experiences with you. I'll explain the name question. I come from Spain, so José is Joseph in Spanish, but Pepe is Joe. It probably comes from the Italian Giuseppe. Spain controlled much of Italy for, what, 300 years. So I think that's where the link is. So Pepe is the same. People often say to me, are you married to Josie? Is she your wife? So no, it's the same. Okay, so that's me. I'm a psychiatrist, and I've run the services for HIV mental health in a big centre in London, probably the largest in the UK for HIV, and I developed the mental health services there. I'm now retired clinically, but I'm doing research and writing still, so I don't see patients now. But we had a very large service for about 26 years, providing assessment and intervention, working with the general physicians and nurses as well. And what I'm going to be telling you about is some of my experience there and subsequent research we've done at the same time and a bit later, hence the two topics. Do stop if what I say is not clear or if I talk too fast or anything, just do. No, I'll use this one, shall I? If it works. No. Okay. Something has gone close. It's gone. I've lost my message there. Can you go back to the? No, but how do I shift it?
You're supposed to be.
It is not. No. We did it earlier. Can we get our lady to help for a minute? I've lost, when we were doing the internet search, I seem to have lost the picture here. We were trying to get the internet for this. But, I seem to have lost my.
Okay, we don't need.
No, we don't need that.
Where is the?
Mine's there, but I just need. Is it working now?
Yes.
And I just press this one.
Yes.
Okay. The pointer. Yes. Okay. Now, what I want to tell you about is something about how the picture of mental health difficulties has changed over time, at least in our experience. Then something about depression in HIV, and does it matter whether people are depressed or not? And then something about the quality of life in older people with HIV. That's going to be much of the focus of what I'm talking about, including what people tell us they do, older people, they tell us they do to cope with aging with HIV. So that's the menu for today. The first part, looking at the changing picture of mental health in HIV, is based on a paper that we published a couple of years ago. The papers here you can access, I don't think it appears there, but you've got copies. It's open access, so you can print it. But basically, this is the only study I know there is where we've followed up, we've looked at people over 24 years, not at the same people, but looking at referrals to the mental health service at different stages since 1990 to 2014, and looking at the diagnosis, the problems that they present when they get referred to us. So it's not a reflection of what's going on out there in the community or what the medics and the nurses are dealing with, is what gets referred to the mental health services. So they're presumably more severe, although there may be all kinds of reasons why they get referred, apart from being more severe. So I'll take you through it in some detail. Now, we're looking at 1990, 95, 99, 2005, and 2014. There's slices of referrals in those years to our service. And what you have on the left is the principal diagnosis. Some people may have more than one, but this is the main diagnosis, right? I'll take you now to the total referrals. In 1990, we had 123 people referred, 306, 360, 406, 490. So the number of people referred to mental health for HIV goes up in that hospital, in the big hospital. Now, I don't know the denominator. I don't know how many people with HIV there were. Obviously, they would be increasing as well. My guess is that the proportion has increased a little bit. It may not be as dramatic as it appears compared with all the people being seen. But, so that's the first thing to show you that we are busy in that service. The second thing is the labels. And look at the percentages rather than the numbers. If you look at depression in 1990, 20% of referrals got the label of depression, 33, 34, 45, 47. So that label has gone up. Without going into details of everything, what's gone down is the acute illnesses, acute brain syndromes, mania, schizophrenia-like illnesses, dementias. That's kind of disappeared gradually. But it's the chronic, long-term problems, often meaning a lot of baggage from the past, which is now coming up as you're beginning to feel better physically. Lots of things keep reappearing. And the label depression is perhaps the short term that covers that, but we'll come back in a minute. But the message is, the picture's changed. People are not coming in a terrible state because they're positive and they're panicking. That's kind of disappeared as well. They're not manic, they're not psychotic, they're not demented, they don't have a brain syndrome in the hospital with PCP. They're coming with long-term anxiety and depression. And that's increasing. As you see, almost half of the referrals are like that. This is just looking at not percentage but numbers. The blue line is the depression. Look how the numbers, how they've shot up in terms of referrals to us. And what's gone down is the acute problems, as it were. In the last year, in 2014, we looked at substances, recreational drugs used by people. And many use recreational drugs. It might not have been seen as the main problem, but you can see what they were taking. Mephedrone, crystal meths, G, cannabis, cocaine. But the main ones that certainly in the UK, in London in particular, are very popular as recreational drugs will be mephedrone and crystal meths. I don't know whether this is the case in Stockholm. Do you have problems with recreational drugs of this kind? A little bit. It's a nightmare in London. And the problem with it is that it affects adherence, increases hepatitis C risk, etc., etc. But as you see, a huge proportion are using them. May not see it as the main problem, because only a small group saw it or was diagnosed as the main problem, but that problem is there. We also looked at people who had HIV and Hep C at the same time, trying to see if their label, their diagnoses were different. They weren't. It's about the same. We thought that the Hep C group would have more depression, more anxiety. In fact, it's very much the same. There's no differences, which is striking. So they're just as bad, if you like, as depressed, but no more. Complex cases. Our service at that stage was very well funded, so we had psychiatrists and psychologists working together in the team. The psychologists were not in another building. They were in the same building. We interacted all the time. We had 2 or 3 meetings in the week when we talked about patients, chat patients, and so on. So a number of patients were seen both by psychologists and psychiatrists, not in the same day, not simultaneously, but typical case would be a psychologist sees a patient, refer to them because he's got some degree of depression, and then they realize that he's got suicidal ideas. So they worry, is this severe depression of the kind that antidepressants might be relevant? So let's get a psychiatric assessment. So they cross-refer to us. And vice versa. Somebody that I've been seeing with depression, maybe treated with antidepressants, is getting better, but there is a whole host of baggage issues that need to be dealt with, and pills will not deal with that. You need psychological therapies. So as they're beginning to improve from their acute depression now, then they get referred to the psychologist. So those complex cases were involving both. Again, we had 174, which is quite a high proportion. It was 40% of all the people we were seeing were being seen by both. And as you would expect, the labels are, in the psychiatry group, more depression and more anxiety in the psychology group. But the theme I was going to stress here is how, by working together, we were able not to give double messages and say, oh, don't take tablets, don't take antidepressants, that's bad for you, you need therapy, or vice versa. We're working very jointly together, both psychologists and psychiatrists, and that was really great beneficial consequences for the patients. That could apply outside HIV too, but often, certainly in the UK, services are very split. And psychologists and psychiatrists sometimes don't talk to each other, they're in different buildings, they get paid differently, they're managed differently. It's a nightmare in that sense. So working together is difficult. Here was, for a period at least, it was very easy to do that and to work together effectively, to the benefit of patients, of course. So you saw there that depression was mentioned as the most common presenting diagnosis now. So how common is depression? This is difficult to read, but doesn't matter because in some ways it doesn't make sense. This is part of a systematic review that Lorraine and I and others did, looking at all the literature on HIV and depression when it was published in 2011 and the years before, trying to see what conclusions we could reach about how common it was. You couldn't reach any conclusion because it went from 0 to 80%. And much depends on, first, what you call depression, how you measure it, what instruments or what method you use. What population are you dealing with? Is this people who've been diagnosed for many years? Is this people who are acutely ill? So very confusing picture. So you couldn't really say 20%, 30% from the published data would tell us how common depression is. We know it is common, but it depends where you are and how you label it, how you diagnose it. So part of that issue is depression the same as being unhappy? We've now got into a world ourselves in our developed country society where we like giving diagnosis to everything and to everybody. And sometimes what is seen as depression may not be depression, maybe a normal way of dealing with whatever problem it is, a trauma, dealing with impending bereavement, past bereavement. Some of those issues may not be illnesses in the sense of depression, but we kind of medicalize it sometimes. And it's not easy sometimes to decide, is this something which is normal and people will just deal with, as they've done in the past, with support from families, friends, relatives, etc., and it has a natural history, or is this something that we need to intervene, the professionals come in and do something, or the support groups? So all the time when we're talking about depression, we need to be very aware, when we talk about psychiatry, we need to be aware that sometimes we may be overextending ourselves, and what we're doing is not necessarily right. We may better rely on support groups, on families, and so on, to provide help and support rather than immediately reach for the prescription pad or for the therapy approach. That may be relevant. I'm a psychiatrist. I've done it all the time. But I think it's about having that sensitivity and that judgment about deciding what is unhappiness, which you don't want to medicate, and what is an illness or something that may benefit from intervention, even if you don't use the word illness in that sense. Okay. Now, let's move on. There's a big study done in the UK called the Astra study, looking at people who are positive and who are on antiretrovirals, on ART. And you see it's more than 3,000 individuals. And in this study, they were looking at the relationship between mood and a number of use of medication and other variables. So just focus on this instrument called the PHQ-9, which let's just look at this section here. The higher the score, it goes from 0 to 27, the more depressed you are on that. It's a self-administered questionnaire that people hand out. And as you can see, the very depressed will be the last two groups. So in this population of over 3,000 people with HIV on treatment, you find that the very depressed group is 6.4 of the whole population, 7.7. So you can see how it decreases in a way with severity, but you still have a significant group. Now, how does that compare with the general population out there? Difficult to be sure. There are a number of studies from other places using it in Germany and so on. There's one from England, 7%, US 6.8, because these are people who are not necessarily comparable. They may not be gay men or former drug users, maybe anybody in the street. But it does suggest that that overall picture of more than 10, which would be the cutoff for being depressed, on that instrument is about 27%, more than a quarter, compared with a much lower figure there. You can do the same with anxiety, with suicidal thoughts and so on. But you can see it suggests that using a particular instrument, comparing with the general population elsewhere, people are more depressed. Okay? But there's more people with depression. But does it matter if people are depressed? Okay, they're unhappy and depressed. We want to help them and make them feel better, whether this is with medication, with psychological therapies, with support, etc. But beyond that obvious element, what do we gain by dealing with depression and treating it? Coming back to that study, this is looking at non-adherence to antiretrovirals. Remember, all these people, in this case it's nearly 3,000, not the whole sample, are on antiretrovirals. And here we're looking at non-adherence, meaning by that, that person has missed 2 or more consecutive days of ART on 2 or more occasions in the previous 3 months. So that's described as non-adherent. And then you look at their mood when they come, and what you can see is that the proportion of non-adherence goes up with depression. So that if you have the highest score on that instrument, 27, 25% are non-adherent. If you have 0 to 4, is 7% or thereabouts. So there's a clear link with how depressed you are, how unhappy you are, and how bad you are at adhering to treatment, how you're taking your medication. It's very neat there, you can see, and that's significantly different. There's other indicators too, but that's the one I want to focus on. What about non-viral suppression of the viral load, which is another way of looking at non-adherence? And again, this is using clinically recorded viral load at the time of the questionnaire. And again, you find exactly the same. The proportion of non-viral suppression is, 18%, or something like that, in the most depressed group. So it's a clear link with, depending on how depressed you are, the higher the score of depression, the greater the likelihood of that person not being suppressed virologically. It's the flip side of. This is virological rebound, having suppressed and then coming up again. The same theme. If you look at the middle section here, again, as you go up, the proportion of people who are rebounding, 25% of those with high scores, the viral loads come up again because they're always not taking the medication. So a clear link. All these things have impact on your health, clearly, and on your life. So clearly depression is relevant. There is a clear link between the two, but that's one way of getting into the adherence, viral load rebound. Everything else is focusing on the mood aspect of it. This was, again, parallel. This is looking at how many people knew their personal viral load level. And if you look at here, is the same story. People with a score of more than 10, which are depressed, 23% didn't know. It's inaccurate. But if you are not depressed, if you have less than 10 points, 13%. So again, your knowledge of what your viral load is, how informed you are, how interested you are, if you like, in your health, again, it's linked to your depression. If you're very depressed or higher level of depression, they're all the same, different ways of looking at the same issue, if you see what I mean. But essentially, it's telling you if you're depressed, your health is going to deteriorate. So there's some value then when I say, is it worth thinking about identifying depression? Clearly, there's an opening there.
May I just
Yep.
make a comment?
Yep.
I think it's really intriguing what you're talking about right now, the clear association between depression and the viral load, adherence, and so on. And we neglect, I shouldn't say we, the healthcare system neglects mental health.
Yeah, looking at that side of it.
Yeah, and then the doctors and nurses get very upset when people don't take their medication. Well, maybe you should start asking questions about their mood.
Yeah. We'll come to that in a second, to the questions as well. This is part of another study related to the Astra study, which is looking at negative individuals. So let's look first at the bottom one, which is, this is the Astra. So this is unsafe sex. This is people who had no sex. These are the positive ones. So this is the percentage of more than 10, in other words, the depressed group on that questionnaire. If you had no sex at all in the positive group, 30% are in the depressed group. Condom-protected sex, they're less depressed. But one unsafe encounter, more than 2, depression goes up. So unsafe sex is also related to your level of depression in the positive group. Interestingly, in the negative group, it's the same. you can see the negative group there, it goes up with mood. As the more depressed you are, the more likely it is you have unsafe encounters. Interesting, the first group, which I thought somebody of you might ask, if you're not having sex, you're actually quite depressed in that group, more than the other one. It may be because you're so depressed you don't have sex, you're not interested, you've gone off the idea. There may be a link between the two things. And the same interesting in that one, people who are positive and didn't have any sex in the period in question, the 3 months before, there may be an element of being quite depressed. They're almost as bad as the ones fully...
Yeah, but no sex is not necessarily a choice.
Exactly, absolutely. But linking it with mood, you can see that because they're so depressed, there's all kinds of factors in it. But I think the theme is, if your mood is bad and it's worse than the day before, as it were, clearly something is going on there that may put you at risk too. Which we knew, but it's so clearly laid out there.
Maybe no sex is making you depressed.
Yeah, absolutely. So sex which is safe would be the good thing. Yeah, it will bring it down. You see the condom protected sex, there you are. It goes down. Yes. You're worried. You're concerned.
No, what I was thinking, isn't it because when you feel better, you also make better choices?
Yeah, absolutely. There's so many factors in it. Now, you were asking, Nina, can we ask the question? This is a study that was produced not far from here in Aarhus in Denmark. And they looked at a clinic where people with HIV were coming along, and they did an assessment using what they call the Holy questions, which I'll show you in a minute, and a standard assessment of depression. And they were able to conclude that with those two questions, a yes to one of those two questions, which I'll show you in a minute, you had a huge sensitivity and reliability. So it was a very good way for the medics and the nurses to identify depression. And those are the questions, which is nothing. It's not complicated questionnaires and forms and so on. Just ask, in the last month, have you felt bothered by feelings of feeling down, depressed, or hopeless? If the person says yes to that, okay, we focus on that person. Or if they say yes to the second one, in the past month, have you often been bothered of having little interest or pleasure in things? Enjoyment and being happy. Now, a yes to either of those questions means we need to worry about this person. We need to focus now. What else is going on there? And it's very easy, very simple questions. But as I was saying earlier when Lorraine was talking, you're only comfortable as a medic or a nurse or a community nurse, whatever, or a volunteer, asking those questions if you know you can do something about it. If you know that, okay, if this person is depressed, my God, he or she might be suicidal, where do I go next? What do I do next? So you need to have a structure, a backing, a support structure that will allow you to... The medics may be very sympathetic, but they say, oh my God, I can't possibly ask every patient this question, because then I'll have 20 patients every morning that I need to refer. So it gets complex. But it's very easy to begin to identify, and these simple things, these woolly questions have been used in other settings in the UK, in antenatal clinics, in other settings, please.
Those are the two main criteria for the DSM.
Exactly. Exactly. So it's quite sensitive. But I think the advantage of this is that it's not a sort of 20-question questionnaire or sitting down with a psychiatrist. It's very straightforward as a screening instrument. Okay, in some cases it may be wrong, but in most cases it's right. And it's very easy. But as we keep saying, you need to know what to do after you've got a yes or two yeses. So what do you do? Again, I won't go into details of it, but the nice organization in the UK is National Institute for Clinical Excellence. There's a national body which is independent from the government, which looks at evidence for treatments of all kinds and produces regularly evidence on what should be used for IBS, what should be used for this, for that. And regarding depression in people with physical illness, there are a number of, they update these things all the time. And the theme really in this is that there's no one answer. You've got a stepped care model. To begin with, you do your screening, and you may then provide some basic support and listening and try to explore what's going on in that person's life. Okay, and I'll see you again in 2 weeks' time, see how you're doing. Then you see in 2 weeks' time, they're still feeling bad, then you may increase the amount of input. You may say, well, can you see the psychologist working here with me in the practice? Or shall I refer you to the local NARC-SARC support group? You know, and then you keep increasing, but you need to be involved. And it's not a question of saying, oh, everybody has antidepressants then, or everybody has psychological therapy, psychoanalysis, CBT, etc. You're sort of all the time monitoring, and obviously if somebody is very, very depressed, you may go step to the top, straight to the top. But the idea of stepped care, you can Google NICE guidelines, all these things are available. You may have a similar thing in this country. But really the theme is Okay, think about it, assess, and be prepared. Have a structure so that to begin with, you do something fairly minimal intervention. But then as things move on, you go somewhere else and you keep increasing. So you need to have your links with services nearby, etc. So it needs planning, it's thinking ahead. It's not that complicated. If you wanted more details about all these things, you can email me at some point and afterwards I'll send you information. Okay, that was on the depression side. Are there any obvious issues that come up in what I've been saying, please?
Yes, I would. You're saying older people living with HIV.
We're coming to that now, yes.
Yeah, we usually here in our organization we talk about people who have lived with HIV for a long time,
Yes, yes.
that not necessarily being old in
Yes,
age,
yes, yeah.
and then also older people that
yeah.
perhaps have not have HIV
Yeah.
a long time.
Yeah.
But
Yeah.
do you make a distinction, or you're talking
No,
about physically older?
I think what's happened in the UK is that people have done a lot of research. Much of the research is on people over the age of 50. And many of those may have been diagnosed yesterday, but many of them may have been diagnosed for a long time. So I think the age boundary has been the key, at least in research, looking at people of the age of, that's what's called older, over 50. Most of us are way beyond that line. And then within that group, people will look at length of diagnosis. Is that relevant? Is it worse if you're over 50 and you've been diagnosed for another 30 years, etc.? So, but I think we tend to use the idea of age as the easier to measure thing. But the two things interact, obviously. So I'm now moving from the depression side to this one, which is the quality of life in older people living with HIV. I've been involved in a number of studies looking at this population and on these issues, and I'll tell you in some detail. Now, really, the question is it all bad news? Because we hear all the time, oh my God, all these people getting old with HIV, what a terrible problem. What are we going to do with them? Hang on, are they a problem? This is success, you know, it's a sign of success. And we mustn't necessarily see it as something to get rid of or something which is problematic. Do you see what I'm trying to say? People doing research or people funding these things do what in the UK is called shroud waving. Shroud is what you put around the body when somebody's died, right, when you bury them. Shroud waving is sort of, look at all these people dying, all these terrible things, which we like doing so we can get funding. So medics get caught up into this kind of world. So when we hear, certainly in the UK, discussions about people aging with HIV, you're very tempted to fall into that trap of saying, oh, well, it's a terrible thing. All these old people with HIV, it's a wonderful thing that they haven't died. It's a wonderful thing they're getting on. Okay, they will raise another issues and we need to face the difficulties there. But it's not all bad news. That's not my theme. It may be bad news in many cases, but it isn't always. And we need to, certainly in countries which have access to treatment, it may not be the same in other countries where things are quite different. But here, you know, we need to be very realistic and look at the picture, look actually what's going on, what is happening there. Okay, so is it all bad news? So what is quality of life? It's interesting that this term, which was there at the beginning of HIV, and I did some research on that, published some papers in the early days when there was no treatment. And the issue was, well, as there is no treatment, really what is important is quality of life. How do we keep people happy and contented for as long as possible? Now that all disappeared, but now it's kind of coming back again. And sometimes quality of life assessment is more interesting than the mood measures and everything else, and because in a way mood comes into it, depression and other things. It's a more global, a broader way of looking at it, as you'll see in a moment. So what is quality of life? It's a subjective measure. It's not something, it's not like functional assessments, but how many stairs can you climb, or how fast can you run, or it's purely subjective, what the person feels his or her quality of life is. And how do we define it? Sit down for this. WHO has this very complicated label, or way of describing it. I'll give you a minute to read. Position in life in the context of culture and value system, goals, expectations. You see what it's saying, that there is no one quality of life, depending where you've grown up, depending where you are, depending what your family expects. So it's a very complex thing that has to do with lots of other factors. So you can't have a questionnaire that says that's it, or a reply. But the point to make is that it's a multidimensional. While depression is about mood, quality of life has lots of different areas in it that define the quality of life. And some of it may be how you feel physically or psychologically, how much money you have, what sort of flat you live in, how many friends you have, all those factors come into it. But the key thing, as I was saying earlier, is not a measure of functional health status. It doesn't tell you how fast you can run, how many steps you can climb, how many whatever. It's a subjective perception of a sort of context, really, in your life, which we all do in different ways. Although we take shortcuts and talk about depression or I feel anxious or whatever, but it's a broader picture here. Okay, so how do we measure it? There's two approaches. One is questionnaires, and there's millions of questionnaires, not millions, scores of questionnaires looking at how to measure quality of life. Some of them very long, and at the end of it, your quality of life goes down because you've been spending all this time thinking about yourself and how to do it. But there's instruments, and there's also qualitative. The whole area of qualitative research, for me, was new. I haven't been a quantitative researcher for years, and now I'm much more into qualitative research, looking at perceptions and narratives and descriptions of things, which again is a whole new area, which has become much stronger, certainly in the UK, in terms of physical illnesses in general, looking at the perception that the person has of how diabetes, cancer affects you, not just saying, oh, you're healthy now, you can go off. So those are the two ways in which we look at things, okay, in quality of life. Instruments, there are many, but the one we've used that I'll tell you about is a WHO Quality of Life HIV brief. It's an instrument that specifically focuses on HIV, and it's been validated in many places. It's a shorter version of a longer one. And the thing about this instrument is that it has a number of domains, a number of dimensions. It looks at physical health and has a number of 2 or 3 questions saying about how physically strong you feel, blah, 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 very serious. It has psychological health, a number of areas there. Degree of independence, how you can get on with your life without relying on other people all the time. How many friends, how many people around you have, or what sort of relationships you have. Environmental health, that means your accommodation, the sort of place where you live. How comfortable, how safe do you feel in your flat? If you're going to knock at the door and invade you or rob you, etc. Spiritual feelings, how do you feel about meaning? It doesn't mean religion necessarily, but do you have a sense of purpose in your life, a sense of going somewhere, that things are happening for some particular reason in your life? And then you have a total score. So you can see how this is much more sort of subtle and looks at many aspects of a person's life as opposed to, are you depressed or are you not depressed? Are you anxious, not anxious? That comes into it, but it's a broader way of looking at it, which also opens up possibilities for intervention. If you find that everybody is having problems with environmental health, living in terrible conditions, well, that's telling you that's an area we need to address, and so on, not just taking tablets. Okay, what do we know about then quality of life in people over the age of 50, to go back to that, living with HIV? There's now quite a lot of literature in the last few years. This is a paper that, one of the early ones that I published with somebody else, a social scientist, where we interviewed 10 MSMs over the age of 50, and without 50 to 78 was the range. And without going into all the details, essentially you ended up with 2 groups of are you familiar with this? Yeah. 2 groups of people who'd been positive for a very long time, had much more negative perception of their quality of life, and they've been struggling, had all the memories of all the people they lost, all their friends and partners. So it was much more, while others, especially the more recently diagnosed, even if they're older, had a much more forward-looking view. And in some of them I say, well, my life is better now than it would have been anyway, because now I go to the doctors every 6 months, I eat carefully, I exercise, my health is better than it would have been if I hadn't had HIV. So very interesting. For some it was a sort of positive thing. They're reframing it in a positive way. This is the same study done in Finland with an Italian researcher and Finnish people. Again, you can see the title, I live quite a good balanced life now. You know, I've control of my life, I'm doing the right thing, and this is people of the age of 50 as well. I won't go into details of all of them. This is an interesting one, which is part of the Astra study as well. They used a different measure of quality of life, but the point I'm making is that the older people with HIV are a bit less over 50s. Their quality of life declines compared with the younger ones, but no more than the negative controls. The negative controls, as they get older, they go down as well in quality of life, but this was no dramatic difference. So it was as expected, if you like, as it would have been for some no not positive HIV person. But let's come back to our own studies, the work we've done with Dana Rosenfeld, who was the lead researcher in a group of us, looking at HIV and later life study, what they call the HUL study. And this was funded by the Medical Research Council in the UK. And this was a mixed method study, so we had quantitative questionnaires and qualitative narratives as well. So we were able to look at both sides of the picture of quality of life. We had 100 people. Yes, please, anytime. Yeah, whenever you like.
Okay, so I ask again then.
But ask me about this. Don't ask me what comes next.
No, before.
Yeah,
okay.
Please.
Well, I was thinking about another aspect. All of us living human beings have to make life choices, you know, regardless if you have HIV or not. And sometimes you regret your life choices, you know, or you're happy with your life choices. But I think that's an aspect with the differences. I saw an interview with myself when I was quite newly diagnosed. And then I said I was very happy to have HIV. This was in early 1990s, because now I know and I have all this, and it is, you know, and I have a happy perspective of my life, even though I thought it was going to be short. And now I sort of think that the life choices I made back then, knowing that I have to live this long, with those choices, you know. So had I known that I was going to survive this long, I might have made other choices. So this is, I think, is something that comes up with many people we talk to, that could differ a little bit, at least, from the general population. That, you know, you were expecting to die, and then you did choices that you...
That's a huge change, isn't it?
Like, for instance, instead of finishing university, you drop university or whatever you do.
Yeah, that comes up all the time, the sense of, you know, what do I do now with my life?
Yes, and So,
thank you. Very relevant. These 100 people that we studied in this particular project, they were recruited from clinics, from volunteer organizations, from support groups, and so on. And we tried to replicate the demographic structure of HIV in the UK. So you have mostly MSM, as you see there, but we have Black African heterosexual women, Black African women, well, we don't know, Black African heterosexual men, white heterosexual men and women. So it's kind of what you would expect out there. They were not completely randomly selected, because that's very difficult to do, but we managed to get from the various places, clinics and everybody else, a representative sample of the populations we're looking at. No, very hard to find them. Well, very hard for them to admit that they were, which is interesting in itself. And I'm sure there are Afro-Caribbean in the UK, indeed, and also Black Africans, but we couldn't find them, interestingly. When you look at the figures, statistic figures, and they're not identified. They don't appear as that, at least when we did the study. But the point to make is that of the 100, we're trying to at least reflect what's out there. Okay. The first paper that I'll mention briefly is the quantitative one, where we use that instrument I mentioned before, the WHO brief questionnaire. And
can I zoom in? The figure you showed on the previous picture, that is the prevalence in UK.
That's the, when you look at the UK. When you look at the UK, whatever proportion is gay men, so that's what reflects what's there. So we tried to reflect what was going on there, not just look at a particular group. So this paper, you can get free open access if you print this later on, but it's there. So the question here was, what affects the quality of life of older people with HIV? So we had that population, we used the instrument, and in that instrument there's one single question which says, what's your quality of life? How do you rate it? And we found that 56% said good or very good, 24 neither good nor poor, 9 poor, and 1% very poor. So 10% poor, but the rest, which is 90%, were quite surprised. But they're saying, well, it's not that bad, which is striking to me. And many said, well, it's actually quite good, more than half. This older population, mixed racial and diversity of all kinds, which was quite a surprise to us, but there it is. So the next question was, okay, can we tell who are the ones that are giving a negative quality of life. What affects quality? So we did first what they call bivariate analysis. We looked at sex, sexual orientation, all sort of items. Yes, no, in relation to quality of life score. And this is what we find. Better quality of life, men got better quality of life than women, reported it. And that applied to the total score, physical, independent, environmental, and social. So most of the dimensions, the men gave significantly better than the women. White people, men and women, had better environmental scores, but not on the other items. People with a partner had better total social relations, psychological, quite a few. MSM, environmental and social relations. And speaking as a gay man, there's always the joke, oh, gay men had lovely sitting rooms, hence their environmental reports have been better. You know, beyond that point, the joke, which I can make, but you can't if you're not gay. Again, some better outcome there. People diagnosed being less than 40 years of age, in other words, quite recently, had better quality of life as opposed to the longer-term diagnosis. Not in on the items, but you can see total and so on. People with higher education, university education, etc., had physical and independence better scores. People with higher income as well, people not on benefits, on social benefits, on state benefits, had better. And the flip side of that is people working, some of them were working, had better in all domains as well. So obviously it's not that we should stop all benefits and people will be better off then. It's not that way that it works. It works the other way around if you're well enough not in the benefits. But the surprise for us is without grandchildren. My thought was that we had quite a few black African women with children and grandchildren. And what we discovered was that if you didn't have grandchildren, you had better quality of life. My thought had been, here they are, you elderly ladies looking after their grandchildren and feeling so fulfilled. The opposite was the case. And when I asked them, they said, no, I feel freer. I don't have to look after my grandchildren. I have a life of my own, which is very interesting. It was counterintuitive. I'd expected that those women, a few men, but mostly women, who had grandchildren to look after would feel they have a purpose and this is a male thinking in the wrong way about what a woman might feel. But it was very interesting that they said, no, we're much happier without having to look after my kids, about my grandchildren. I can do what I want, which is interesting. So, and that was in terms of independence and total score, and the environmental. The kids didn't spoil their rooms, their flats, etc.
Can I ask, could that be driven by the sample having a lot of gay men who didn't have grandchildren, and they have a better quality of life, which we sort of
I'll answer the question in a second, because we'll say people attending religious services as well had better. When we did the multivariate analysis, looking at everything being put together, then it still appears there, to my surprise. So who had better quality of life? People not on benefits, or black African ethnicity. Interestingly, we thought that the black Africans would have worse quality of life, but in fact it comes up, men and women, physical, psychological, and spiritual. Again, those were the ones that perhaps had church links as well, in some way. But that was interesting. And MSM, environmental, being partner as well was, as you would expect, a protective thing. And not having grandchildren came up as well. So these are all once you've put everything in the pot, all the variables, and try to tease out what's really significant and is not interacting with something else, those were the ones that came up as predicting better quality of life. So just to go back to it, not being dependent on the state for benefits, in other words, probably working, although working didn't come out as one of the black African ethnicity. Again, that may be having to do with what they expected before and what they have now, I don't know. MSM, being partnered, again, we know that from the literature and psychological and social issues generally. If you have a partner relationship, provided it's a reasonable relationship, then you're better off. And then not having grandchildren. So that was interesting. But I think, for me, the main question, the main point of this quantitative study was the very first slide, which is, my quality of life is not that bad. In most cases, they were saying only 10% were really feeling not right. The majority, which is, again, we may be talking about a sort of country where there is access to treatment, a country like the UK where, in spite of all the political tightening of benefits and everything else, people are still getting some benefits. and getting some state support, although that's always very difficult to get these days. But in other countries without those elements, you don't know what would be happening, obviously, what the situation would be. So that's the quantitative. What about, oh, there's something else that I didn't mention. We use also the everyday memory questionnaire. You know all the concern about dementia and HIV/AIDS dementia, which was in some ways a myth because it never quite was as bad as it was thought to be. It was there, but it wasn't as common, and it's kind of disappeared now, unless it's combined with other things. But there's been concern about this, and we've done a number of studies in over 50s coming to the clinics doing screenings with different instruments. And one of the instruments used was the everyday memory questionnaire, which is totally subjective. And you say, how is your memory? Oh, I keep forgetting my keys, or I left the car and I don't know what the car is. Things that we all do in different ways. But so you can look at that subjective rating. When you look at that group, studies, and you look at standardized memory, cognitive assessment, they're not depressed. They're not brain impaired, they're depressed. They have anxiety and depression problems rather than brain impairment. But anyway, we used that instrument in this study as well. And we found that those that gave poor sort of ratings of memory, of their own subjective memory performance, yes, sorry.
So I'm just wondering if you have compared this to a questionnaire with answers from people that do not have HIV?
It's been used elsewhere in other conditions, yeah. and you can pick up people who are concerned about their memory. It's been done with lots of physical illnesses, diabetes, multiple sclerosis, and so on. And clearly, those people, compared with controls, have higher worse scores.
Okay.
Yeah, but I think when you look in detail, certainly in HIV,
but also like in general, even the
general population.
Ones.
Yeah.
That would
it's
be
been done
really
as well.
Interesting to see the
they're
difference.
not as bad. This is worse.
Yeah.
But what is interesting when you look at them is they're not brain impaired. They are depressed or anxious. They're concerned about their performance rather than having dementia or anything like that.
Okay.
So as an instrument to screen for brain impairment was no good. As an instrument to identify people who might be depressed or anxious was much better in that sense. But the point with this is that if you had poor self ratings in every memory questionnaire, you also had poor quality of life. So again, it's linked. And with anxiety and depression, we had some measures as well. So clearly you're looking at a whole host of things that come together: poor quality of life, being depressed, etc., concern about your memory. And again, that may be another instrument that if you're using it to look at screening for brain problems, although it's not very good, medics might use that as a way of alerting themselves. Okay, let's move on to the qualitative now, because in that study we had the questionnaires, which I'm telling you, but also we interviewed 100 people, were interviewed by a researcher, then the interviews are transcribed, and then they're analyzed in detail, and you look at all the contents and so on. So, what we want to do is say a little bit about what problems they identified, these 100 people, in terms of coping with, us aging with HIV. But second, and this is going to be the main element, what they found helpful to cope with those problems, what strategies they were using themselves. Now, very brief, that's been published as well, so you can, when you get the copy of the presentation, you can identify the paper. What did we find? What difficulties did they report? Just briefly. Mental health difficulties, being depressed, being anxious. Stigma, the interaction between ageism and HIV, feeling very self-conscious about going to places for older people and having to say, well, I'm HIV positive, or not say it, having to hide it. All that element still kind of unresolved, the stigma element. Relationships, either forming them or maintaining them or managing what they have. And again, if you remember from the quantitative study, being partner and having a relationship was a good thing in terms of quality of life. So here you have this group that for some this was a problem, obviously. Financial, housing, immigration problems being identified. And then, of course, as we get older, we develop other illnesses. People get diabetes, arthritis, backache, cancers, all sorts of things. So you accumulate conditions. And that, again, that's another factor that comes here. We can become very focused on HIV, but there's lots of other things going on as you get older that may be relevant. But I want to focus on the strategies, which is the kind of thing that you and I are involved in trying to help. So what did they tell us they were using to deal with older people living with HIV to cope? I'll give you first the list of the items. The first one was reframing the situation, gaining control over one's life, trying to make sense of what was going on. The second was emphasizing the value of relationships. The third one was gaining help and support from external agencies, being able to access support, in particular from other people with HIV, groups or otherwise. Doing things for others came up as a theme as well, and valuing financial security. Now, the way research on qualitative things works, you don't set up what the answers that you want. You look at what's been said, and then you build a picture from what people are telling you. That's important to them. So all these categories were generated by the people themselves, and then we lump them together in this way. So it's not that we decided, gaining control is important. They told us it was. Okay, I'll give you some quotes. This is somebody who describes, this is a gay man. What's wrong with us? We're fit and healthy. We're probably healthier than other people walking the streets now. We're checked every 3 months. We're given £1,000 worth of pills every month. What's the problem? Why are we concerned? So he managed to, this man is an MSM, has managed to reframe his situation and say, okay, hang on, I'm still here and I'm coping well. Now, if medics said that, that would be seen as unacceptable, but it's him saying it, it's himself saying it, which is interesting. Another one, I like my life. What I had to learn was to stop doing everything. All you need is a roof over your head and be able to eat. This is a white woman with HIV, which is interesting. She's sort of, so, okay, she'd been a businesswoman. She was busy doing millions of things, flying here and there, and all sorts of things. I said, hang on, is that important? It isn't. This is what matters. So I'm retrenching a little bit, but this is a gay man again. I got determined and positive about quality of life when I did a program at the hospital to build strength, sort of physio. I thought I needed to take some control. As you get older, you need to make a rock for yourself. I find new things, little things, like going down to the river at Richmond, just in West London, and having a walk there gives me enormous pleasure. I'm not waiting for death in a room on my own, which is what it could be. So I'm enjoying every day and doing new things. So again, he's kind of turned the picture around. Okay, relationships. I mean, in your relationship, she's one of us. She's positive. She says, I don't have anybody to go to church with. People need a relationship. We need practical and emotional support. This is a black African man describing how, through getting involved with another black African woman in a support group, is giving him some sense of we are together now. This is a gay man. I have a life. I have a bloke who loves me, who fights with me every day. I have a sex life. What else do I need? I've been quite isolated for a long time, and one thing I have learned is that I'm not totally isolated because I'm connected to HIV people, and that fundamental connection from one human being to another is absolutely imperative to being alive and finding happiness. Seems a very theoretical and very sort of conceptual way. This was a white woman as well, which is interesting, but now she's kind of reformulating her predicament in this way through links in practice and in theory. I'm happy because I have kids, black African man. Had children and had managed to bring them over from whatever country he was coming from. Now, of course, we talked about relationships, but then the question of emotional and sexual relationships is a problem for some of them. And from another part of the study, which I'm not going into detail today, the two strategies people were using was either avoidance, I don't get involved. It's not going to work. I don't want to disclose. I don't want to fail sexually. Keep away. Or I look for people who are also positive. And then at least that pressure is off, and whatever happens, whatever we do sexually. So again, there was lots of quotes about difficulties and so on, but those are the main two strategies. Either I get out of the picture, I don't compete, I avoid it completely, or I find someone who is like me and I don't have to hide it. Briefly, this is a study we did some years ago, looking at the prevalence of sexual dysfunction in men. There was nearly 800 people, European study, and about a third of men, this was straight, heterosexual, homosexual, various groups. A third of men describe erectile dysfunction of a significant level, and about 20% loss of interest in sex. And you can look at factors. There was nothing clearly related to a specific medication. The longer you've been in medication, the more likely it was. And people over the age of 50 were much more likely to run into problems, as you would expect. But there was no specific one single cause. There was quite a combination of things. And Lena is here, and again, her paper with colleagues, again, looking at not just sexual dysfunction, but also emotional difficulties and difficulties engaging with others. Again, very common in people who are positive. And it's not just simply a question of taking Viagra for the men. It's much more complex than that. It's a huge emotional burden and relationships. Again, very interesting paper to look at in detail. Okay, what about the next few strategies? Support from external agencies. Again, I've got a Freedom Pass and I still get a DLA. These are very British things. Freedom Pass is a traveling card that allows you to travel free. And some people who are physically unwell qualify for it. So he must have qualified, this man, gay man, MSM, for this. And DLA is Disability Living Allowance. It's a benefit. Many of these things are changing, are getting very hard to get. The state, the government is making it very difficult for people to, they say, oh, HIV has been treated, it's not a problem anymore, you're fine, you don't need anything. So it's that tendency, it's there. But he's saying, well, I had help from the outside, and London Lives helps me. This is an organization that provides practical support as well. So external help. Therapy, I talked to my psychologist about my concerns. This was a woman, black African woman. Again, this is a gay man, that's right. Getting support, getting medication, joining in support groups and so on. So again, having access to support in different ways being a factor. Somebody else. Again, interesting that therapists come up here a lot. People mention quite a few, receiving therapy and support being helpful. But this lady, again, black African lady, she told me cognitive therapy, and when I get depressed, I use it, and I don't need to see her again. I just get on with it. So being resourceful in that sense. Doing things for others, this is interesting too. I'm doing voluntary work, keeps me active. I was teaching people, older people, to deal with computers. I'm an expert in computers, so I'm teaching them. So I'm doing something that gives me meaning, gives some sense of direction. I'm a carer. Now this is, when you read it, it's a bit alarming, because you feel this person has too many needs, which is dealing with by being extra nice to people, and perhaps he needs to stop and think about himself. But you can see what he's saying. Doing things for others helps him to cope. Why not? He's doing something. It may be that he will get burned out at some point if he keeps doing it, but you can see the message. Seeking support from other people with HIV. Again, this is about joining groups and having access to organizations like yours or the various support groups. Black African Woman, both of them relying on groups quite effectively. I'm rushing a little bit because I'm conscious of the time. But, okay. And then having financials, being safe economically, obviously, is not surprising, but some of them mention it as a specific thing, and not having to depend, and perhaps some of them are working as well. It doesn't come out there. So what I was saying, they recognize their difficulties. We mentioned at the beginning physical problems of all kinds, other issues, stigma and so on. Some are HIV related, some are not. They struggle to manage them, and they cope with them in many ways. And some have developed strategies, as we're hearing here, which are obviously having some effect. And they've done it themselves. They're telling us that's what they're doing. To what extent they always work, or to what extent they are fully effective, we don't know, but there they are. And I think we need to not only encourage, but also evaluate all those self-generated ways of dealing with things, which is not what the doctors or the psychologists say, is what they're telling us, the people with HIV. So I think this is all I wanted to tell you today. So if there is anything else or any other questions that you have. You always have questions.
Yes, I do.
Please.
You know,
Yes, please, please. Please do.
No, get out of my head now. You can come back.
Okay. I think it's been a long afternoon, so we can stop soon. I think the message I was giving with the two parts, one is the depression and the mental health, and the aging with HIV, is that certainly depression is not uncommon, and it has effects beyond being unhappy and making you sad and perhaps suicidal. It has effects on your physical health. And it's not that difficult to identify those people. The question is what you do about it, and you need to be well disposed and well prepared and have the right resources. And in terms of the older people dealing with HIV, it's not as bad as we feared. In fact, many, in our sample at least, are coping reasonably well, and they have all kinds of ideas as to how to deal with it. So in that sense, it's reassuring. But I don't know to what extent is the same in Stockholm, in Sweden, what your experiences of older people. Are they fairly well adjusted, some of them? Are they relying on you and then getting on with things? What's your experience?
we could talk about that as well. Is this one on? I do have a question, though.
Please.
It would be interesting if you could... I imagine that most of these conclusions are done before the partner study came, who was presented. I mean, we all known for quite a long time that you don't transmit if you're on a treatment.
Yeah, yeah.
But this is also one of the major concerns is not necessarily whether you can contaminate or not, but it's certainly an issue. And so let's say that you would do these kind of studies, and after 10 years' time, has the perspective changed? You know, are people less concerned about transmitting? Are people less concerned being transmitted? Because people are still concerned in older care houses or whatever, and you would meet people that would have they will take things like if they were having a sexual context, you know, where you can't work here with older people because you have HIV, and what do you expect them to have sex with your stuff? And even knowing that you can't even with good medication transmit. So I would like to see this study done again in the future, and then perhaps to see if it has any effect on. Does the knowledge of transmission help you? And also...
I mean, I don't know about Sweden, but in the UK, HIV is seen as a problem dealt with. It's not a problem anymore. So everything is sorted. People take pills and they're fine. So anyway, in many ways, all the educational element of teaching the general public about, okay, if somebody is really with no viral load detectable and is taking the treatment, they will be okay. They don't need to use condoms. They can be... That hasn't quite got to the general public yet. Whether it will ever get, I don't know. I remember reading a while ago an article in the press by a gay man who had used condoms all the time and now was using PrEP, the pre-exposure prophylaxis. And he was describing the experience of, for the first time, not using a condom in a contact that he'd had. And the first time, he just burst into tears. He just felt so bad about it. The sense, oh my God, what am I doing? Although he knew it was okay. But he was in a terrible state. And then the second or third time, he was okay. But you see, even that is in somebody who knows all about what's going on, the emotional load attached to it that comes with it. But if you look at the general public, the stigma will continue for ages, unless you have the education and say, look, this is okay now. But of course, you need to be very sure that this person is taking PrEP or his viral load undetectable. So it's an ongoing battle, and my point is that we've stopped educating, certainly in the UK. It's been done. HIV is not a problem anymore. It's gone. So I think that's quite worrying.
It is very worrying.
Thank you so much for your facilitation. We appreciate it. But it's mind-boggling that UK thinks that HIV is not a problem anymore, because even if you take tablets and you are adherent and things, all these things you've been talking about take an emotional load. It's sickness of its own. Yeah.
But I think in the same way in which at the beginning of HIV you had all those terrible headlines in the papers and everywhere else, you know, all this, the gay plague, etc., etc. Now the media's lost interest. They move on to something else. So, and in a way we're very much influenced by the media, and what we hear, what we read, television and so on. There may be scandal and then everybody's aware of it. For example, in the UK now there is a lot of attention, some attention being given to the problem of people with haemophilia, or people who had blood transfusions, who got in the UK not just, they got Hep B first, then HIV, and then hepatitis C. Although the government said all along, no, this will never happen again, it's happened again. So there's a bit of attention now going on again on the question of a legal case to get further restitution and so on. But beyond that, I don't see much about HIV anymore at the moment in the press, in the UK. And it's that sense that, oh, it's not a problem anymore. Why are you worried about it? And that may be why there's been even little attention given to PrEP, because I thought that the right-wing press, the sensationalist press, might be saying, oh, look at this, you're encouraging them to have sex and no condoms. And there's been limited attention. There was a little bit at first and now it's gone. So in a way, as I said, people have lost interest, moved on. The media has moved on to something else. And when that happens, the public kind of follows, unless you really actively press and argue. So.
It is quite good that nobody, I'll speak on behalf of people living with HIV because I live with it. I think in a way it's good No one wants to be looked upon as sick or incapacitated. It's kind of good that the masses are being educated about the fact that we live with HIV. There is nothing really. I mean, other people have health issues too. But at the same time, I think this, what you've been talking about, mental health and stuff, should not be disregarded because they take a toll, and also about side effects. Nowadays, there are so many medications that have come up and new, which has not been in existence for a long time. That's also a cause to worry. So many people have developed a lot of side effects, and it's really a challenge.
Yeah. It's about being realistic and understanding what's going on. I was saying at the beginning how people say, oh my God, people aging with HIV, what a terrible thing, all these old people with HIV. Well, that's very good news that older people are surviving. But of course they have problems, so we need to see what the problems are and what we need to do. So it's about having an accurate rather than newspaper-led understanding of things. I think that's the problem. Please.
Hi, Pepe. I have a question. In the geriatric literature, they define what they call the young old and the old old. And I was aware that your cutoff was 50, and really, as we joked, 50 is not that old, depending where you're standing. But in your data, did you have any sense of the differences, say, between the 50 and the 65?
It didn't come up at all.
Be working,
it didn't come up as a factor.
70-year-olds.
Because we have 87-year-old.
Yeah.
And it didn't seem, the age itself didn't seem to matter. What's how long you'd been positive, that was the factor in that sense. So age didn't seem to matter. It's just interesting. Yeah. There was something else I learned the other day. You were talking about side effects, and I hadn't realized that with PrEP, there's some side effects to PrEP in the sense of osteoporosis, if you keep using it repeatedly. And I wasn't aware of that. All of you may know about it. So you may need to take precautions with vitamin D and various things if you're taking. So it's interesting, things, they're always a side issue to everything, a side effect, consequence. So nothing is pain-free, as it were.
Thank you for your presentation. It was very nice. I just want to make a comment. I talked to some of the people who live with HIV who is older, and some of them tell me, it's so good, because if I look to my friends who are living not with HIV, they don't get the same controls, and I can go to my doctor, and I have these follow-ups, but my friends who doesn't live with HIV, they don't have it. So, and they say, I have really nice values and everything is looking great, but my friends who doesn't have HIV have a really bad shape or something else. I think it's good to turn it around as you told.
To be realistic as well, because not everybody will be as fortunate as that, but some will have friends, and we need to be aware of it and not assume that everybody's fine. So there is, I'll just mention very briefly, in the social science literature, not just in HIV, but generally, there is a lot of debate about the neoliberal view of aging and death. And this may be familiar to you. Neoliberalism is a sort of economic and political view of viewing the world. It began with Reagan and Thatcher, and now everybody is neoliberal, which means the state is very small, and it's all up to individuals. It's up to you. You can survive, you try hard enough. Nothing to do with the state, that model. What is economically neoliberal, now it's been translated into other areas. And think, for example, of obesity. People who are morbidly obese. It's very easy to say, well, aren't you lazy? You should be trying harder, eating the right thing, But if you take a sort of that's a neoliberal view, it's your fault. But if you look at the context, these people are people who may have less access to healthy food, the educational factors play a part, they come from areas of unemployment. It's a global issue, it's not an individual fault. The neoliberal model that is up to you, slim ladies in the 80s who go to the gym 3 times a week and so on, they can afford to do that. So but you know what I'm trying to say. And it's the same with aging and with death in HIV. There is this debate now about dying well and aging well. Well, we're all going to die. So somehow to say, if you get sick and die, it's your fault. They're not saying that, but that's the theme. You need to be very careful. Hang on, there's global issues and contextual issues that play a part in how we age. And the idea of aging well you're getting caught into this neoliberal model that says it's up to you to age well. If you don't age well, it's your fault. You know, when it's much more complicated. You've got, you know, access to resources, access to treatment, educational abilities to that support at home. So we need to be very aware of that risk of, we need to age well and we need to die well. Of course, we want to do all those things too, but in a wider context, not just as pointing the finger at you and saying it's up to you if you age well or die well. And of course, in HIV, people still die. And what's happening now, we've been doing some work on the narratives of death in HIV in the 30 years that we know about it in the UK. And what is interesting is that when you look at now, in the early days, everybody talked about death, and you went to see the doctors with your living will to have plans as to what to do if you died. Now it's not mentioned. For the doctors, it's failure if you die, because we have all the treatments, you shouldn't be dying. You know, and for the people with HIV, there is a risk of that happening too, to some degree. So somehow, death is pushed out of the picture, somehow. Well, we need to sort of bring it into life as well. And it's one of the consequences. Okay, you can struggle, but you'll do your best. But then we need to, don't deny it. It will come. That applies to HIV and to everything else, to all of us. But it's very tempting within the HIV world to pretend death is not happening anymore. It's happening. People kill themselves. People take drugs that kill them, recreational drugs. So it's interesting. So we get caught into this whole paradoxes of success and the neoliberal sort of emphasis. And I will stop now. Oh, yeah, exactly. Yeah. Stigma is interesting. Yeah. We were talking to a community nurse, I can just say one thing, dealing with people with HIV in Liverpool, of all places, and she was describing the case of a young man who, I think he acquired HIV vertically, but he now is terrified of going to the HIV clinic because he doesn't want anybody else to see him going there. So the community nurses go and give him the medication 2 or 3 times a week at home. And the point that the nurse was making is, HIV won't kill him, stigma will kill him. So it's still there. So, yeah, I'll do stop now, yes.
All right. Well, thank you very much, Pepe. I think your presentation, just like Lorraine's presentation, really have given us a lot of considerations and concerns, and I think there are many, many similarities between the UK and Sweden in terms of the consequences of living with HIV infection, both for women, men, and children. And it's very, very important, of course, that we keep going and really continue our struggle. It's not over, although we do have the pills, but that's not the end of the story. So, having said that, and thank you very much, we have come to this little handover ceremony. And as you all might know, is that Riksförbundet Noaks Ark, or in English, the National Federation of Noaks Ark Associations, confers annually the diploma Guldarken, or the Golden Ark, to acknowledge and honor persons who in different ways have contributed substantially within the HIV field. So this year, we would like to award Barbara Hedge, who is not here, as we know that. She's in Kent, but she has been informed about this award. And Lorraine Scher and Pepe Catalan with the Guldarken for your diligent, voluntary, considerable and very important work with regard to the AIDS Impact Conferences since 1991. And what I really want to emphasize in this sentence is your voluntary work. It's amazing how people, also 2018, does anything without getting money. And I think that is really what impressed us, is all the work you put there. It would have been okay for 1 year, well, but now it's over 30 years, which is really incredible. And that's why we really want to award you. And it's a very simple award, but it's really to show you our admiration and that you keep fighting HIV in different ways. Because the AIDS Impact Conferences, they do continue. They take place every second year, and in July next year, 29th through 31st, the 14th AIDS Impact Conference promises to keep and miles to go will be held in London. And there are some cards here making PR for the AIDS Impact Conference. And I really highly recommend that conference. I have no shares in the AIDS Impact, so I can really say that from the bottom of my heart. So I wonder, there you are. So this is a little diploma. So here it says, now you have this in Swedish, you need a dictionary. But anyway, it's about this, what I've told you already, actually. So Guldarken har tilldelats, jag har awarded Lorraine Share, and it's the date, and it's signed by me. So please, you're most welcome, and I hope, maybe you can put it somewhere on a wall. Yeah, okay. So thank you so much. And then, you have the same and the dictionary? Okay.
We will. Thank
Yes.
you very much.
Okay. Yes. And Pepe and Lorraine will take also diploma to Barbara Hedge, and I heard you will see her tomorrow. Yes, so we'll get it tomorrow.
Thank you very much.
You're most welcome. And now it's open for mingle, and there are some sandwiches and wine, and you know, socialize, and you have some time to spend here as well. I think the taxi will pick you up 5:15. Okay, 5:05. So then you are safe.
Thank you very much, Nina.
You're welcome.
Very grateful to all of you. And